Yeah.
Okay. So we are going to be talking about SGLT2 inhibitors. It's the new hope in CKD. And we know for a fact that there's been multiple trials on various combinations with aliskiren, with glycosaminoglycans and anti-inflammatory drugs, which have not yielded any positive results. So all the positive results in the treatment of diabetic nephropathy or even non-diabetic nephropathy begins and starts with ACE inhibitors and ARBs, and all this stopped about 15 years ago. Since then, we've had no kind of positive outcomes. But SGLT2 inhibitors, when they were first came into the market, because of their ability to block proximal glucose and sodium reabsorption, it obviously led to increased sodium delivery to the macula densa. And this leads to the tuberoglomerular feedback, which leads to reduced intraglomerular pressure and reduced proteinuria, and additional downstream effects with the decreased albumin excretion and improved cardiac function and increased hematocrit logically leads to improvement of renal function. And this is why we were very hopeful when SGLT2 inhibitors came into the market that they would be very good for reducing the impact of diabetes on kidneys. And the CVOTs that were initially published with renal endpoints, the EMPEREDGE, CANVAS, and the DECLARE, these were, of course, post hoc analysis, and all of them showed improvement in nephropathy as well as improvement in worsening of proteinuria. Thereafter came the CREDENCE study, which showed a reduction of doubling of serum creatinine with reduction of dialysis or transplantation and CV death, and a composite of reduction of end-stage renal disease, doubling of serum creatinine or renal death, or dialysis or kidney transplantation. Thus providing the rationale for CKD that, that this group of drugs seems to be very good to reduce not only CV problems, but also CKD. And also there was this data which was coming out from the DECLARE and the DAPA-HF, which was showing that not only does dapagliflozin improve heart failure and renal outcomes, there is improvement in heart failure or death composite from CV causes. And all of this was showing an improvement in renal outcomes, which is why a trial particular and specific to CKD was conducted, which was done in patients more than 18 years of age with a eGFR of between 25 to 75 and a urine ACR of more than 200 to 5,000. People who were on a maximum tolerated dose of ACE inhibitors or ARBs with or without diabetes, who were standardized to dapagliflozin or placebo, about 4,300 patients with a composite outcome of sustained doubling of creatinine, ESKD, renal or CV death. This composite is started to be known as MAKE, or major adverse kidney events, and also secondary outcomes like composite of sustained doubling of creatinine, ESKD or renal death, or additional of composite of CV death or heart failure and all-cause mortality. This was a study which had lots of participants from across the world. There is often a criticism that there were no Indian participants. As you can see, there was a large number of Indian participants as well. As you can make out, these trials, the DAPA-CKD and CREDENCE, CREDENCE had mainly diabetes population. This had mixed population, as you can make out. They all had poor renal function with less than 60 eGFR and an elevated urinary ACR. And how high was the ACR? The average ACR in both the groups was about 1,000 milligrams per gram, which you can make out as a huge amount. And their eGFR was pretty low. They were all in stage 3 CKD with a eGFR of 43. Systolic blood pressure was low. About 70% had diabetes across the world, and a mean age of 62, with roughly about 70% men and 30% women. What is most important to note is this is maximum therapy with ACE inhibitor, A inhibitor. Almost everybody was on ACE inhibitor and ARB. The etiology of CKD, if you look at the overall population, the main thing was diabetic nephropathy. There was also hypertensive nephropathy and chronic glomerulonephritis. Other things like chronic pyelonephritis and obstructive nephropathy and chronic interstitial nephritis provide a little bit of the burden of patients. Type 2 diabetic nephropathy, largely they were diabetic nephropathy, In addition, there were patients with hypertensive nephropathy and chronic glomerulonephritis, and patients with no diabetes. They were mainly patients with chronic glomerulonephritis and ischemic nephropathy, along with other miscellaneous causes. What we saw was these patients had a pretty high creatinine of 1.7 on average, 1.6 in the diabetes group, 1.8 in the non-diabetic group with low eGFR. The maximum number of people were in the group which had an eGFR of between 30 and 44 and large protein excretion, with a large amount of people having macroproteinuria. And when the primary composite outcomes were declared, there was a sustained reduction of greater than 50% eGFR decline, end-stage kidney disease described by dialysis or transplantation, renal or CV death. As you can make out from the p-value, it doesn't fit into the box. It is so persuasive, 0.00000028. There was a statistically highly significant reduction of all these events with the use of dapagliflozin 10 milligrams. That was 39% relative risk reduction, translating into an NNT of 19. Normally, an NNT of less than 100 is considered to be a very good NNT, and an NNT of 19 is very, very, very impressive. In addition, we found that there was a improvement with dapagliflozin across the board. All patients with diabetes or not, patients with macroalbuminuria or not, patients with low eGFR or not. In addition to that, patients who were hypertensive or not, elderly or non-elderly, race, geographic region, all of them was found to have a massive reduction in all the renal outcomes with dapagliflozin. The secondary outcomes, which was sustained reduction of doubling of creatinine, as well as end-stage renal disease and renal death. Again, as you can see, the p-value doesn't fit into the box, and again, it's highly persuasive, a 44% relative risk reduction, and also an exploratory composite outcome of chronic dialysis, transplantation of relative renal death. This was also reduced 34%, as well as the CV death or hospitalization for heart failure was reduced 29%. Also, a secondary outcome, all-cause mortality, was also reduced by the usage of dapagliflozin when compared to placebo. The safety outcomes were all very good, no kind of bad signal, no signs of diabetic ketoacidosis, no signs of fracture or amputation, which were seen by the users of dapagliflozin. So to summarize, DAPA-CKD is the only SGLT2 trial in recent times to have met all primary and secondary endpoints. The first treatment with or without type 2 diabetes to improve cardiorenal outcomes and reduce mortality. As you can see, this is how it is summarized. No type 2 diabetes in 30%, 70% type 2 diabetes. Large study with poor renal function and proteinuria. And there was a 39% relative risk reduction with the NNT of 19, which I told you was extremely impressive. In diabetic patients, it was 36% relative risk reduction. In non-diabetics, it was even more, 50% relative risk reduction. It was well tolerated with no adverse outcome signals. So this is again a summary of all the benefits that you see. 44% relative risk reduction of all these composites, reduction of CV death, these are all secondary outcomes, and 31% reduction of all-cause mortality. And it was so impactful that the trial was stopped early, and due to the overwhelming efficacy, it was felt that patients should not be kept away from this treatment till the completion of the trial, which means that almost everybody who has diabetes should be put onto this to prevent diabetic nephropathy or the worsening of diabetic kidney disease. Now, this it has to be taken into consideration with all the other trials that have been done with dapagliflozin, the DECLARE, the DAPA-HF, and the DAPA-CKD, which makes it very clear that dapagliflozin is not only useful in reducing heart failure or CV death or worsening heart failure in patients with or without diabetes, it is also magnificently useful in reducing the risk of CKD and the implications of CKD thereof, not only in patients with diabetes, but also in patients without diabetes. Thank you very much.